got bile acid malabsorption and they've responded to cholestyramine, then is it lifelong treatment, or how long do you treat them for?
It's usually lifelong treatment, so I think if they respond then, because cholestyramine is fairly unpalatable, you might think about referring them for a CCAT scan. I think there's someone at the front.
We often see patients with dyspeptic symptoms who, when given a PPI, they're sort of asymptomatic, and then immediately on stopping, their symptoms come back. In the absence of any sort of red flag symptoms, is it reasonable, independent of age, that such patients can carry on with a PPI without investigation if there's no red flags, normal blood counts?
Yeah, so if it's dyspepsia, carry on. If you think they have reflux symptoms, then those patients who who are over the age of 50, they're overweight, they're smokers, and males, and have nocturnal symptoms, you would consider that they have gastroesophageal reflux rather than dyspepsia. And it's that group of patients that may have Barrett's esophagus. So it'd be not unreasonable to refer those patients for a routine endoscopy to exclude Barrett's esophagus. But it is safe to continue with PPI's PRN.
A quick question on use of SSRIs in functional dyspepsia. I couldn't quite catch your advice on that. When do we decide to start SSRI? And can SSRI itself cause any GI symptoms?
All drugs can give rise to GI upset, as you know, but patients who have functional dyspepsia, like irritable bowel syndrome, they have a higher incidence of depression, anxiety syndromes. So it's particularly in this group of patients you might consider SSRIs and antidepressants. And there is increasing evidence in control studies that it has good evidence in both functional dyspepsia and irritable bowel syndrome.
We get asked quite a bit about long-term use of PPIs and bone protection, and so what's your take on that, and when should we consider?
Yeah, so the side effects, a slight risk of osteoporosis, there's an increased risk of micronutrient deficiencies, and there's an increased risk of nosocomial infections, bacterial overgrowth, and patients on ITU, they get increased risk of infections. Those are kind of main side effects of proton pump inhibitors. But you have to assess the risk-benefit ratio. Patients who require proton pump inhibitors, usually patients with reflux disease or Barrett's esophagus or non-ulcerative dyspepsia, they have a poor quality of life. And that quality of life is improved significantly by proton pump inhibitors. So the benefits in that group outweigh any of the risks. The risk of osteoporosis development is small, but there is a risk, and so you have to discuss that with the patient on an individual basis.
I've got two questions. How long after H. pylori eradication therapy, if the patient hasn't responded, should we repeat the test? And the second is, what about slightly raised bilirubin? How do we investigate, and what are your suggestions on that?
Okay, so the question regarding H. pylori, you've got somebody with dyspepsia, you've tested for Helicobacter, it's positive, and you've prescribed them standard triple therapy eradication regime. So assuming that they've been compliant and they've completed the course, the eradication is going to be efficacious at about 90%. So 10% of patients won't be eradicated. And if they've got persistent symptoms, that's when you probably want to check their Helicobacter 4 weeks after antibiotic usage. And if they have persistent H. pylori infection, then you could prescribe them quadruple therapy at that stage. The other possibility is they've actually cleared the Helicobacter, but the Helicobacter hasn't made any difference to their symptoms, in which case they're going to have functional dyspepsia, and the treatment of choice would be proton pump inhibition or prokinetics. As far as the high bilirubin, I think this...
Slightly elevated bilirubin is actually very common. I assume you mean isolated bilirubin by itself. Almost certainly this is Gilbert syndrome. And if you want to reassure the patient more, you can simply repeat the bilirubin, do a split bilirubin, and you'll find that the unconjugated fraction is always more than the conjugated fraction. When you've got that in hand, you let the patient know that this is an entirely benign disorder. In fact, it affects 5 to 7% of the general population, so it's actually very common. The main advice I give them is keep well hydrated, good rest, and the main thing is don't go through prolonged periods of fasting. If they do go through prolonged periods of fasting, then that's when the bilirubin goes up, and they may look a bit slightly jaundiced, icteric, or maybe a bit sallow looking and feeling a bit tired. So just to reassure them that there's no significant liver disease underlying this. The bilirubin may even go up to as high as 70, 80 or 90 at some stage, okay? But that's perfectly acceptable. Anything over than that, then there may be some rare genetic disorders such as Crigler-Najjar type 2 or something.
I have 2 children. I don't know why they had the blood test. It was by another doctor. But one of them is about 5, the other one about 3. They have alkaline phosphatase marginally, just a little bit above the highest range. We repeated it after 3 months, and we did vitamin D then. Vitamin D came normal, but the phosphatase came low, and alkaline phosphatase is still high. Would it be still due to vitamin D deficiency?
No, is the gamma GT elevated?
No, we didn't do that.
Okay, so this is bony cause, okay? Frequently in children, you do see the alkaline phosphatase hover a little bit around the thresholds. In fact, if you look at the alkaline phosphatase, there are different reference ranges for children, women, and men, okay? And if you look at that from children's perspective, that's probably quite a normal reading for them. So I think this is a natural history of growth.
Just a quick question about how long can we give prokinetics like domperidone because it increased the QT intervals?
So the QT intervals it's really, the caution about QT intervals is that in patients who obviously got cardiac disease, but it's at the higher dose use of domperidone. So the standard uses that we tend to use in the UK, 10 milligrams TDS, I don't think there's major concern about QT intervals in that kind of dosage. It's really the 60 milligrams and higher doses. That's where the problem with the QT intervals are. The good thing about domperidone, it is a peripherally acting prokinetic, so it doesn't cross the blood-brain barrier unlike the other ones, metoclopramide does. So less risk of other side effects with domperidone. So long-term it's safe, providing you use at low doses. In the US, it's actually banned. The FDA in the US do not allow use of domperidone. And I see that the European, I got an alert just, I think, yesterday or something about domperidone and QT intervals use of, and it's really the higher dose use of domperidone is not allowed.